An intraoperative transesophageal echocardiogram, or TEE, can be performed for a number of reasons. Common Category 1 indications include cardiac valve repair or suspected thoracic aortic dissection, heart and lung transplantation, placement of cardiac assist devices, or surgeries in which there is high risk for myocardial ischemia or unstable hemodynamics are examples of Category 2 indications. The equipment needed to perform a TEE includes an ultrasound processor. The processor is connected to a TEE 5 to 7 MHz multiplane probe. A tongue depressor, a laryngoscope with blade, an orogastric tube, and ultrasound gel are also required. The patient lies supine on the operating room table with the head supported by a standard foam pillow. General anesthesia is induced and the patient is intubated. After successful intubation, an orogastric tube should be placed. Lubricate the tip of the tube. Place the tube into the patient's mouth. Slide the orogastric tube into the esophagus by lifting the mandible anteriorly while simultaneously advancing the tube into the stomach. Attach the tube to suction and empty the gastric contents to allow for improved echocardiographic imaging. Remove the orogastric tube. Prepare the ultrasound transducer. Cover the transducer's scanning surface with ultrasound gel. Use the wooden tongue depressor to displace the tongue from the soft palate. Fill the posterior oropharynx with ultrasound gel. Hold the ultrasound probe in neutral position and align it with the natural curve of the patient's tongue. Gently lift the patient's mandible anteriorly and place the footprint surface against the tongue. Advance the probe into the hypopharynx with firm pressure, continuing to anteriorly displace the jaw. The greatest resistance occurs as the probe advances through the upper esophageal sphincter. If you have difficulty passing the probe into the esophagus, try one of the following approaches. Have an assistant perform a posterior jaw thrust. With the tongue displaced from the posterior pharynx, you should gently attempt to advance the probe. Alternatively, perform laryngoscopy to visualize the esophageal opening. Laryngoscopy provides a direct line of sight, allowing you to guide the probe into the upper esophagus. After the tube successfully passes through the upper esophageal sphincter, advance the probe in neutral position through the lower esophageal junction and into the stomach antrum. Separate the cover from the interface block and plug it into the TEE processor. Stand at the head of the bed directly superior to the patient. The transesophageal echocardiogram can be done in several ways. However, it is important to establish an imaging sequence such that all the cardiac and vascular structures recommended by the American Society of Echocardiography and the Society of Cardiovascular Anesthesiologists are viewed. As you establish a viewing sequence to perform the TEE, remember to utilize the various ultrasound modalities in each image. Here we start in two-dimensional mode to identify the anatomy and follow with color flow Doppler to discern blood flow characteristics. Spectral Doppler may also be used to further characterize blood flow. Shown here is an example of continuous wave Doppler and pulsed wave Doppler. The transducer's imaging plane can be rotated from 0 degrees to 180 degrees as seen in the image. This enables the physician to view several images of the structure of interest while the probe remains in neutral position in the esophagus. Forward or backward rotation refers to movement within the different planes. Clinically, this may be referred to as multiplaning. These terms are interchangeable. When learning TEE imaging techniques, the probe movement should be slight and subtle. The novice tends to make large, gross movements of the probe and resultantly can miss the imaging plane needed to view a particular structure. We begin imaging in the transgastric plane with a short-axis view of the left ventricle. If the patient has known valvular disease, advance the probe into the body of the stomach and anteflex the probe. Gently withdraw the probe to the gastroesophageal junction to obtain a deep transgastric long-axis view. This view provides a picture of the aortic and mitral valves as well as the left ventricular outflow tract. It is particularly useful to evaluate flow dynamics because the ultrasound beam is often parallel to blood flow across the valve. Use color flow Doppler to evaluate aortic valve function. Perform a second color flow Doppler exam of the mitral valve. Mitral regurgitation is noted. Spectral Doppler may be employed in either the aortic or mitral position to characterize valvular flow abnormalities. From the same view, inspect the left ventricular apex for an apical thrombus. This view is particularly useful in patients with prosthetic mitral or aortic valves, in which acoustic shadowing may prevent adequate visualization of the left ventricular apex. Allow the probe to return to neutral position. Gently withdraw the probe and anteflex the transducer foot against the gastric wall to reveal the left ventricular short-axis view. In this position, two-dimensional transgastric views of the left ventricle are obtained at the 0-degree imaging plane. Slowly withdraw the transducer to obtain views of the left ventricular apex. Withdrawing the probe slightly while keeping the foot anteflexed produces the transgastric mid-short-axis view. Continue to withdraw the probe to evaluate the mid-papillary level. Finally, inspect the base of the heart. Transgastric views are obtained when the probe is inserted to depths of approximately 40 to 45 centimeters. The basal short-axis view is recognized by the transverse view of the mitral valve leaflets. Moving from the basal view to the mid-papillary level, assess left ventricular global and regional function by evaluating the 16 ventricular segments recommended by the American Society of Echocardiography and Society of Cardiovascular Anesthesiologists. Acoustic shadowing may interfere with visualization of one or more images of the left ventricle. Rotate the image plane forward to 110 degrees to attain a transgastric long-axis view of the left ventricle for optimal visualization of the 16 segments. Here, the posterior and anteroseptal walls are well visualized and can be assessed for segmental left ventricular function. Observe the posterior wall at the top of the screen and the anteroseptal wall toward the bottom of the screen. Backward rotate to 90 degrees to identify the inferior and anterior walls of the left ventricle. The figure illustrates that backward rotation from 110 to 90 degrees brings the anterior and inferior walls of the left ventricle into view. Rotation into the transgastric long-axis views of the left ventricle enables the physician to adequately visualize and assess the left ventricular wall segments. Backward rotate slowly to 0 degrees. Turn the probe to the patient's right to bring the right ventricle onto the left side of the screen. You can identify the right ventricle because its walls are notably thinner than those of the left ventricle. After identifying the right ventricle, withdraw the probe 1 to 2 centimeters. This image provides an optimal view from which to begin evaluating the coronary sinus and to assess right ventricular free wall contractility. Keep the probe turned to the patient's right and withdraw it into the esophagus. The scanning plane remains at 0 degrees. This brings the mid-esophageal 4-chamber view onto the screen, an ideal imaging sector to examine the structures of the right side of the heart. Evaluate the right atrium and ventricle. Note the presence of the pulmonary artery catheter in the right atrium. Add color flow Doppler to evaluate the tricuspid valve. Tricuspid regurgitation is noted. Pulsed wave Doppler may also be used. However, because the spectral Doppler beam is not parallel with blood flow in this view, it is not an ideal image for spectral Doppler interrogation. Continue the assessment of the right side of the heart, noting the function of the right ventricle. Examine the chamber contraction by watching movement of the tricuspid valve annulus and the thickness of the ventricular wall. In addition, the interatrial septum may be examined. Slowly turn the probe to the patient's left to attain a clear view of the 4 chambers. This leftward turn of the probe develops the classic 4-chamber mid-esophageal view of the heart. Visualize the left atrium, left ventricle, and right ventricle. Identify the interatrial septum and interventricular septum. If the left ventricular wall segments have not been completely visualized, additional images may be viewed by slowly rotating the plane forward to 90 degrees. Here, we obtain the mid-esophageal 2-chambered view of the inferior left ventricular wall on the left side of the screen and the anterior left ventricular wall on the right side of the screen. This figure demonstrates the echo sector change from 0 degrees to 90 degrees, as just completed by our transducer. Here, the mid-esophageal 4-chamber view develops into the mid-esophageal 2-chamber view, which allows for additional assessment of the 16 ventricular segments. Evaluate the global and regional left ventricular function. Identify the chordae tendineae and papillary muscles of the mitral valve. Forward rotate the plane to 110 degrees into the mid-esophageal long-axis 3-chambered view as a means to visualize the left ventricular outflow tract and aortic root. The mid-esophageal 3-chambered view provides additional views of the posterior and anteroseptal walls of the left ventricle. It can also be used to further assess the mitral valve. Identify and assess the posterior wall and anteroseptal wall of the ventricle. Backward rotate the plane to 0 degrees. With the probe turned slightly to the left, the 4-chamber view emphasizes left-sided heart structures. This is an ideal imaging sector in which to evaluate the mitral valve. Examine the appearance of the valve leaflets in 2-dimensional mode, assessing the structure and motion of the valve. Apply color flow Doppler to assess the mitral valve. Mitral valve regurgitation is noted. Pulsed wave Doppler allows the practitioner to evaluate the low velocity of mitral valve inflow. It is limited, however, in its ability to display higher velocity flows. Continuous wave Doppler is a better choice to evaluate the high velocity flow of mitral regurgitation. The constraint of continuous wave Doppler is its inability to accurately localize the site of highest velocity. Withdraw the probe approximately 1 centimeter and rotate to the patient's right and left to identify and interrogate the pulmonary veins. We begin with a 2-dimensional examination of the left superior pulmonary vein. Proceed to evaluate with color flow Doppler. Follow with an assessment of the vein using pulsed wave Doppler. Gradually turn the probe to the patient's right. Identify the right-sided pulmonary veins. Color flow and spectral Doppler may be employed to further evaluate the right-sided pulmonary veins. Slowly withdraw the probe approximately 1 centimeter into the esophagus. At a depth of 35 to 40 centimeters, the mid-esophageal 5-chamber view develops. The sector plane remains at 0 degrees. The sector beam projects at 0 degrees to form the 5-chamber view. This is one of the easiest ultrasound views to recognize while performing a TEE. If at any point during the echocardiographic exam the practitioner is unable to identify a structure or is unsure of his or her orientation, it is advisable to return to an easily identifiable image or structure as a reference point. This includes, but is not limited to, the mid-esophageal 4 or 5-chamber view or the short-axis image of the aortic valve. The 5-chamber view includes the 4 chambers of the heart as well as the left ventricular outflow tract. This is an optimal imaging sector for assessment of left ventricular outflow tract obstruction, as well as the ventricular surface of the aortic valve. You may use color flow Doppler to evaluate for aortic valve insufficiency. With the aortic valve in the center of the screen, rotate the image plane forward to approximately 30 to 45 degrees, while slightly withdrawing the probe. Develop the mid-esophageal short-axis view of the aortic valve. This echo sector produces an ideal view of the anatomy of the aortic valve. The non-coronary cusp is adjacent to the interatrial septum. The echocardiographer can evaluate the aortic valve anatomy in the 2-dimensional mode. Identify the left, right, and non-coronary cusps. Evaluate the degree of mobility of the 3 cusps of the aortic valve. Apply color flow Doppler mode to examine the valve for aortic insufficiency. Rotate the probe slowly, looking to identify the coronary ostia. Color flow Doppler may be used to detect the presence of proximal coronary blood flow. The diagram depicts the normal coronary ostia and aortic cusp anatomy. After identifying the right and left ostia, turn the transducer to the patient's left to develop a view of the left atrial appendage. Evaluate the appendage for the presence of thrombus. Color flow Doppler may be used to assess blood flow in the appendage. Turn the probe to the patient's right until the interatrial septum is well seen. Apply color flow Doppler to interrogate for an atrial septal defect or patent foramen ovale. Rotate the imaging plane forward to between 60 and 80 degrees to develop the mid-esophageal right ventricular inflow-outflow view. This imaging sector includes the right atrium, tricuspid valve, right ventricle, right ventricular outflow tract, and pulmonic valve. Use the ultrasound in 2-dimensional mode to identify the right atrium, tricuspid valve, and right ventricle. Moving to the right on the screen, you can see the right ventricular outflow tract, pulmonic valve, and main pulmonary artery. This imaging sector provides additional views of the tricuspid valve and right ventricle. It is also an ideal imaging sector for structural assessment of the right ventricular outflow tract and pulmonic valve. Both structures are evaluated using two-dimensional and color flow Doppler. Rotate the image plane forward to 110 degrees. Gently turn the probe to the patient's right. This scanning position is called the mid-esophageal bicaval view, so named because you can assess the superior and inferior vena cava inflow into the right atrium. The superior vena cava is seen on the right side of the screen as it enters the right atrium. The pulmonary artery catheter is the echo-refractile structure seen in the atrium. The IVC is not well seen in this particular image. However, it can often be seen in this echo sector, usually on the left side of the screen entering the right atrium. This view also provides an image used to evaluate the interatrial septum. The fossa ovalis is also visualized here. You may apply color flow Doppler in this view to examine the septum for a patent foramen ovale. Return the probe to the midline position by slowly turning it to the patient's left. Stop turning the probe when the aortic valve is positioned in the center of the screen. Rotate forward to between 110 and 135 degrees to obtain a mid-esophageal aortic valve long-axis view. You may need to change the depth of the probe to bring the aortic valve into a centralized position. The mid-esophageal long-axis view reveals the left ventricular outflow tract, aortic valve, and aortic root. The left ventricular outflow tract is designated by the labeled arrow. Proceeding to the right, identify the aortic valve, the sinus of Valsalva, the sinotubular junction, and the proximal ascending aorta. With the ultrasound probe perpendicular to the long axis of the aortic root, identify the aortic cusps. Depending upon the imaging field, the cusp at the top of the screen could be the left or non-coronary cusp. The right coronary cusp is toward the bottom of the screen and is adjacent to the interventricular septum. Using the caliper feature, this is an ideal image from which to measure the diameter of the aortic annulus, as well as the sinus of Valsalva and the sinotubular junction. Withdraw the probe slightly and forward rotate to 130 to 160 degrees. This should reveal the proximal ascending aorta. The figure illustrates a classic view of the mid-esophageal ascending aorta long-axis view. The right pulmonary artery is at the top of the screen. To continue evaluation of the great vessels, rotate the imaging plane backward to 0 degrees. Slowly withdraw the probe to bring the ascending aorta onto the center of the screen. Posterior to the aorta, the pulsating structure is the right pulmonary artery. Within the artery, identify the pulmonary artery catheter. The superior vena cava sits to the left of the aorta on the screen. Use the caliper feature to measure the diameter of the aorta in this image. The proximity of the vascular structures, as depicted in this figure, illustrates the ability of the TEE probe, when positioned in this region, to capture an image of the great vessels in one echo sector. Turn the probe slightly to the right to bring the bifurcation of the main pulmonary artery and left pulmonary artery into the viewing sector. This is a key image to obtain should you need to evaluate for a proximal pulmonary embolus or saddle embolus. This anatomic depiction of the heart demonstrates the relationship of the superior vena cava to the aorta and pulmonary vessels. The ultrasound probe, when placed at this level, is able to obtain an inclusive view of the vascular structures. Turn the probe 90 to 180 degrees toward the patient's spine. Identify the descending thoracic aorta. Withdraw the probe along the course of the aorta until the transducer is at the level of the distal aortic arch. With the probe footpad at the distal aortic arch, note the depth of the probe at the central incisors. Pathologic findings within the descending thoracic aorta can be localized by noting the distance the probe was advanced from the mark at the central incisors. To complete the examination, survey the cardiac structures that need additional or advanced imaging. Secure these images as they are needed for patient care. If the patient is hemodynamically unstable, obtain a transgastric view to rapidly assess biventricular function. Limited additional images of areas of suspected pathology should be obtained next. Should the patient be in cardiac arrest, the priority is to examine the areas of suspected pathology. Once hemodynamic stability is achieved, a complete TEE should be performed. With the transducer foot in neutral position, withdraw the probe from the esophagus and oropharynx. Inspect the teeth and oropharynx for signs of injury. An abbreviated exam can be performed during surgery should the patient's care necessitate a repeat evaluation. A second complete exam is required following cardiopulmonary bypass.